Hello, everyone. This is Mark Plaster. I'm the Senior Executive Editor of Emergency Physicians Monthly, and you're listening to EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us. Sometimes personal, sometimes professional, educational. We just talk about what's important. And today, my guest is Dr. Khan Siddiqui. You've gone through several iterations of career. I know you started with traditional radiology, and then tell me a little bit about your Yada Look and IG, and now Hyperfine. We'll talk about Hyperfine here in a minute, but tell me a little bit about your career trajectory because it's not the usual one.
Yeah, so I started my career in radiology, focused on MR, was director of MR at University of Maryland, and but got into in my academic track more into machine learning and computer vision in the early 2000s, 2004 timeframe, and had this company in natural language processing that you just mentioned that got eventually sold to Nuance Communications. I then moved to Johns Hopkins, was director of imaging informatics over there, again focusing on computer vision, machine learning, AI stuff. This is 2005-6 timeframe. And then in
Moving
2000, yeah, way ahead of everybody else here right now. So, and then 2007, I got recruited by Microsoft to help start their first healthcare AI team and medical imaging team in 2007-8 timeframe. So I did that, had an amazing career at Microsoft, running engineering teams, solving a lot of big problems in infrastructure and AI and things like that. Worked on things that ended up becoming part of Xbox Connect, using human recognition to recognize humans during gameplay. Worked on stuff that became part of Microsoft Azure, storing images in the cloud. And then left to start my next company called Higi. It's a medical device kiosk that you see in grocery stores and pharmacy. So the blood pressure kiosk grew that to about 12,000 kiosks deployed in North America, and pretty much every grocery chain and pharmacy that you go to now has a device. And then recently exited that actually to Babylon Healthcare. And about 2.5 years ago, got a call from Dr. Jonathan Rothberg, who founded Hyperfine, to this crazy idea of getting the portable MRI scanner to the patient bedside. And he's like, how do we, really make this happen and take it out? So came on board, got it through regulatory approvals, and build the entire commercial team and scaling the team right now. So I'm currently the chief medical officer and chief strategy officer at Hyperfine.
So, I got to know Hyperfine because they were the same Jonathan Rothenberg. Is that right?
Rothberg, yeah.
Yeah, Rothenberg was also involved in the launch of Butterfly, one of the first handheld, low-cost ultrasound machines that really made us start to rethink how technology could be placed in the hands of more and more people. They took the Butterfly machine was a fraction of the cost, something that literally every physician could afford to have. And so it didn't surprise me that Jonathan would find somebody like you with a health informatics background, AI background,
and MR background.
MR background, to take something as expensive and as permanent, and what is a better word to say? When you put in when people think of MRI, they think of a massive machine that is millions upon millions of dollars. It stays in one place. Everybody comes to the machine instead of vice versa. And every iteration, every generation of MR seems to be more expensive and more difficult from that perspective. And you and Jonathan completely turned that on its head with the Hyperfine. So start with describing. Unfortunately, I don't have a picture of it right now, but start with describing the Hyperfine portable. This is impossible to think in a lot of people's eyes. A portable MRI. Describe that for us.
Yeah, absolutely. I'll start with a little bit of story, right? So Jonathan always starts with something that has impacted somebody he loves, and then solving that problem to create a social impact. So after going through a bunch of different personal reasons, he realized that MR is just too complex analogy of a mainframe, right? So why is MR a mainframe and not a laptop computer, right? So how do we take the systems verticalization, and that is happening in all industries, miniaturization, electronics improvement, power management is getting better, AI is getting better, and take something that requires a dedicated room in the basement, specialists to use it, and bring it to the masses. Exact analogy of a mainframe computer to a laptop computer that everybody can use. And that's how it started as a vision. How do we bring it? And the way, it took Tesla to reimagine a motor car. And why didn't Ford, GM, or anybody else come up with the first electric car? Because they were stuck in the combustion engine and they couldn't get out of it. And they all could think of as a hybrid scenario. And it really required the Tesla to rethink and build a completely integrated car. And that same thing happened in Hyperfine scenario. When once the team realized in the early days that we can't have a fixed location. In the traditional MR scanner, everything is based on homogeneous magnetic field. And to do that, you almost have to build the magnet at the site and have to shield the room so that you have perfectly clean homogeneous magnet. You have no interference from the environmental noise from electrical issue things, as well as RF signal, plus constant temperature. You need a special HVAC unit because the MR sensitivity changes with even 1 degree fluctuation in temperature. So suddenly all these things had to be thrown out. And once the team realized that they don't have to rely on a homogeneous magnetic field and they can address these issues in software.
Yeah.
Completely rethought of how to do this happen. So we invented a noise canceling technology to cancel out electrical noise in the environment. We came down to a permanent magnet that is low field, so there's no risk of projectile. We figured out how to correct for inhomogeneity in the magnet in software so that you can get perfect images every single time. And then we used, a lot of advanced reconstruction and sampling technologies to enhance the signal to get the image quality almost to a 1.5 Tesla scanner type scenario. So what does the scanner look like? Right, it's a 4'9" tall, about 33" wide, tiny machine that can be driven through a joystick on the patient's bedside, and with no risk of.
For the listeners, if you haven't seen it, think R2D2. Okay,
exactly.
It's kind of round, and it's on a roller. And I was shocked the very first time I saw it. I thought, this can't be an MR. This cannot be. It's too small. And at the last ASEP that we had in person, I was invited to a demonstration of it, and they offered food and drink, which is what I went for because I thought, this can't be for real. This honestly can't be for real. And they had it set there in the room. Okay, brought it up to an elevator and was sitting there, and you could go over and have your drinks while somebody was getting their head scanned.
Exactly.
And it was shocking. It completely turned MR, if you will, on its head. And so if you're seeing this, hearing this podcast, and you have not seen the Hyperfine machine, you owe it to yourself to actually look at that and see its miniaturization and portability. And your point of saying it addressed all the basic issues that were defining the parameters of MR: temperature, magnetic isolation, all these things, and took a different approach to it, and resolved that in a different way. Instead of assuming that was going to drive the MR, which personally I think is brilliant. I think it's brilliant. Now, okay, so one of the things, let's talk about the use of AI now, because one of the things that the initial issues with Hyperfine was the resolution of that. And I remember 2 years ago when they were talking about this, they said these were things that could be addressed likely with artificial intelligence. Let's talk about that a little bit.
Yeah, so in MR, there are 3 types of resolutions. Number one is a spatial resolution, which is what we typically talk about, which is the pixels. So, for example, a traditional 1.5 Tesla scanner would have 1 millimeter by 1 millimeter pixel size. Our pixel size today is 1.5 by 1.5 millimeters. So not that much, slightly bigger. And again, pathology that small, clinically is probably irrelevant, right? Then the second one is contrast resolution, which is difference between the bright and the dark portion of the image. So interestingly, at low field strength, you have a higher contrast resolution than high field strength. It is because of the hydrogen recovery properties in the with the magnetic field. On high field scans, the hydrogen atoms recover fast. In low field, they recover slowly. So you can appreciate the gradient differences in contrast because of the slow recovery, because you have hydrogen in different states that you can capture it. So so it actually has a higher contrast resolution at low fields versus high field. And third is temporal resolution, which is probably the biggest one that impacts us, is how fast can you image again and again and again? So can you do real time? So I think probably the limiting factor is really the temporal resolution, because we have to wait to generate enough signal, capture enough signal to generate image. So our scan times tend to be a minute or 2 minutes longer. So that's traditionally what the three differences are. So from a spatial resolution point of view, we are almost there at 1.5. Contrast resolution point of view, we are probably better than 1.5 Tesla. It's the temporal resolution on how fast it takes to scan the time is probably the one that is the lowest one around it. And we're working on improving those things also. And think of the same way as you think Tesla, right? Tesla does a software upgrade, increases battery life, increase the range, increase speed. And that's how we are thinking about our device. And we keep doing updates very frequently. I think we've done 4 updates just this year so far. We are approaching artificial intelligence, deep learning in 2 different approaches to our scanner. One is just the reconstruction of the image, and other one is providing clinical decision support on the image. So our first application that we got clearance from FDA was actually on clinical decision support, in which we automatically capture the volumetrics of the ventricles to assess hydrocephalus or recovery from hydrocephalus, automatically assess midline shift to assess there any pressure in the brain, and how much of that shift is happening, and then understanding the brain volume. So if you're trying to use any kind of application that using brain volume as a biomarker, now you get a standardized approach to be able to quantify the volume of the brain accordingly. So that was our first FDA cleared AI application on it. We are currently in review with FDA. Hopefully in the next 30 days, we'll get a clearance on our deep learning reconstruction. And it does 2 things. There's a very interesting approach how the team took. So we don't apply our deep learning in the reconstruction on the pixel, but we apply at the what I call the frequency domain, or when we're capturing the data. And we do what is called advanced gridding. It's complex physical terminology. It's just getting a better signal out of it. The other one is denoising. So we apply machine learning to remove the noise from the images and do advanced gridding that enhances the resolution, the spatial resolution of the image. So those are the 2 things that we do in our deep learning algorithms to get the images to look like 1.5. And we've just started, right? This is the first version of our deep learning that's coming out in the market, and there's so many things that we can do to make it equal to 1.5, even get it better.
That is amazing, and you've made that kind of progress in just a very short time period.
Yeah, absolutely.
Where are your programmers? Who's your team working on all the software?
So our team's headquartered in Guilford, Connecticut, near Yale New Haven. So a lot of our engineering team is there, and then they're scattered all over, right? We have people in California, we have people in New York City that do development around this, and we have a lot of different partners in London, UK, and other places also that help us in a lot of the work that we do.
That's absolutely fantastic. What are you going to be doing at ACEP this year?
So ACEP is an amazing opportunity for us. I mean, the portable MR is inevitable, right? We've come out as the first one, and you'll start seeing more and more things coming out. It's like inevitable the way robotic surgery was. When Da Vinci first came out with from intuitive to surgical, they were doing cardiac surgeries, and you knew when you saw it that that's where it's going to go, but it was very expensive. Didn't understand the clinical value proposition, but now it's becoming same thing is happening here. And then what we're trying to do is we're not actually replacing 1.5 Tesla or conventional scanners. What we are trying to do is really we fill the need where access and time are the 2 issues. If you
Yeah.
need imaging right now, and if the imaging is too far away, and most of the time, especially replacing CT scans, if you think of that way, right? How many times you have patients sitting in the ER waiting for either CT scan or MR scan to open up to do something? I mean, here you can drive the, have the scanner or SOOP scanner right next to the patient in the bay and just get the scan done. I mean, if you have a pediatric ER, how many times kids show up with hydrocephalus shunts and they're just waiting there for the imaging to get done, and you just have a length of stay problem in the ER. So at ACEPS, we're showcasing our latest imaging technologies, our latest apps, and focusing on use cases of altered mental status in the ER, any kind of stroke application in the ER, hydrocephalus in the ER scenarios, and evaluating those patients accordingly. And stroke obviously is a big one.
Yeah. If you don't, I'm speaking to our readers, our participants here. If you don't practice in a university setting that can get you into MR on 24/7, then you really do need to think about how you're going to address that. And this is a potential for putting MR into the hands of literally every ER in the country, every one of them, around the globe for that matter. I mean, are you promoting this internationally as well, or because I think that I do a lot of work in developing countries, and I've thought many times how it would be a great leap. I work in Africa at various locations, and it's amazing how that they don't have fixed landlines for phones. They leaped over that and have cell phones everywhere. You go to you go out to Tanzania and to on the big game preserves, and you'll see a guy, a Maasai warrior, walk up to you, and he'll flip out his flip phone and start not flip phone, but his iPhone, and start taking pictures or communicating with other people. They've literally jumped over a whole generation of technology, and this would be an example where they would jump over the technology that we have gotten used to in this country. And I would really like to see Hyperfine, open up those gates and let the flood happen.
Yeah, I mean, we have a partnership with the Gates Foundation, Raising Malawi Foundation. So Gates Foundation is putting 25 scanners in limited resource settings. Their first scanners went out in Pakistan, in Uganda, in Malawi, South Africa, and a bunch of other places. It's another one going to Ethiopia soon. Then Raising Malawi put a scanner in Mercy James Pediatric Hospital in Blantyre, Malawi. I mean, that site got a scanner, and we couldn't travel because of COVID. So all the training happened through Zoom. They took the crate out themselves, uncrated it. They scanned the first patient 4 hours after delivery of the scanner. It's unheard of. It is completely unheard of, right? The MRI scanner takes 2 weeks, 2 months to deploy and train. And here they were
it's
running.
literally a plug and play.
Yeah, and they've done more than 200 patients so far and making such a big difference in patient care over there. I mean, the nearest MRI scanner to them is 5-hour drive.
Yep.
Right?
Yeah,
I mean, it's and the first case was a beautiful case. It was a case of they thought it was cerebral malaria because that's what the unit is focused on. And immediately on the MR, it shows FRES syndrome, posterior reversible encephalopathy syndrome, which is due to hypertension, right? Uncontrolled hypertension caused that. And all you have to do is control the blood pressure, and it's addressed as not cerebral malaria. Otherwise, the child is comatose, right? So that was a brilliant first example in which immediately made a difference in patient care, where just is not possible before. So I think when the reason, Jonathan, one of the early things he focused on is that we need to solve not just developed world problems, but also limited resource setting problems, and make sure we are in those settings earlier on so we understand their needs. You understand the scanner has to work in 100-degree weather, understand it has to work in fluctuating power requirements. It has to go through doors and settings that are traditionally not seen here. And that's one of the goals we're trying to fulfill.
Oh my gosh. That is so exciting. That's absolutely breathtaking. For anybody who has actually practiced or been involved in hospitals in developing countries, I hope you can see how important, how vital that kind of capability would be. The hospital that I helped start a pediatric hospital in Nairobi, Kenya, one of only two serving all of Nairobi. And I frankly don't know how many people live in Nairobi, but I think the last count was over 7 million. And so the idea of being able to bring that level of care, into that setting is just breathtaking. I mean, just is amazing. So I'm really, really thankful that you're applying, you're thinking outside the box. That Jonathan is looking at problems and solving problems. One of the things that I particularly enjoyed reading about your profile was that you said, in talking to another interviewer, you said you don't start something and then look for a problem. You start with a problem and actually look for the resolution, for the answer. And I think that is so true. That is so true here. There's a lot of different folks who have gadgets and inventions and whatnot that they're looking for a problem that's going to, COVID certainly did that. People who came up with an idea, but really it didn't address a major problem. Here you're looking at the problem. How do we make an MRI scanner something that appears, or would you'd think would be completely immobile? How do you make that mobile? Did you ever think you couldn't achieve that, or are you the kind of thinker who said, no, we could figure that out, we can do that?
So I'll say two things, right? One thing I said, there are three stages of a product. The stage one is impossible to do. Stage two is difficult to do, and stage three it's done, right? So we started with MR. Everybody said it was impossible to do. Then when we got to it, everybody said it was very difficult to do, and then I was done, right? So so when you focus on the problem first, right, and you marry to the, and that's first thing I did when I came on board. I told the team, what problem are we trying to solve? Like, what is the why we are here? And everybody would say democratize healthcare and make it and create a social impact at the same time. It's like, okay, fine. So if you do an MR scanner, what happens next? Like, if MR identifies some abnormality, then what's next? Well, you need a neurosurgeon to do some kind of intervention. I was like, well, you haven't really democratized anything by just doing it. That's why we expanded our vision at Hyperfine to democratize healthcare by making sensing, imaging, and guided intervention affordable and accessible to everybody around the world. So we're not just an MR company, and you will see us coming out with products that are before imaging, that are providing image guide, more sensing, so that any community worker, any caretaker can actually apply something on the brain and get an idea what is happening, to imaging, that is follow on after something's abnormal by sensing. Now you can actually image and see what's inside it. And then guided intervention, maybe into robotics in the future, where you can have a general surgeon, or even in a limited resource setting, surgical tech be able to do, or even tell robotics based procedures that somebody can guide and do in those settings. So you have to think through the problem you're trying to solve, and then come up with some solution that can actually address those problems. You start with the idea first, then you get time boxed and boxed into that one thing, and you don't think through the problem completely. And that's kind of what we are doing, is really understanding our problem very deeply so that we can build solutions around that. MR is just one thing we are doing. You will see a lot more exciting stuff coming out of it. And one of the big focuses, Jonathan's, was that it has to be affordable, right? Instead of the $2 million you pay for MR scanners, conventional scanners, and another $500,000 cost in construction, our device is very affordable. We do a subscription-based pricing in the developed world, and we have other interesting pricing options for limited resource settings also, and it's cheaper than a service contract for a conventional scanner.
That's crazy. That's absolutely crazy. I live in Annapolis, Maryland, and one of the surgeons that I work with who you may be familiar with, has established teaching surgical residencies all across Africa, in which using robotic surgery, he's not only able to do the surgery but able to teach the surgery.
Yeah.
From Annapolis, Maryland. And this is what you're really talking about when you say you're taking a technology like this and literally putting it in the hands of when you don't have physicians, okay, and then someone in the middle who actually can image it and then diagnose it and then use it secondarily for the caregiver. What a tremendous what a tremendous vision. Jonathan is to be congratulated for his vision, but definitely you are to be congratulated for the implementation. You made it happen. Thank you so much.
As I said, this is a team effort, right? Not individual effort. So building the right team, everybody coming together to solve these big problems and executing on it. So we've built an amazing team, and that surprise me every single day with new ideas and new innovations to solve these problems.
Well, it is the humility of leadership like yours that attracts people around you that are both capable and free to innovate and execute at the level that you are. And I congratulate you. I congratulate Jonathan for his vision and all of his work so far. I'm anxious to see what's going to actually come out of this. I can see that it is just the beginning. And when you inspire that kind of a dream of a democratization of healthcare, what an impact! What a beautiful story to tell. So, thank you.
Thanks, Mark.
We've gotten to the end of our time, and it passed like that. Thank you so much for taking time out of your day to talk about this incredible opportunity. I hope it's inspiring as well as informative. So, thank you all for joining EP Talk today, and I hope to see you soon.